All right, welcome. We're about to deconstruct the incredibly complex, often chaotic machinery of bipolar disorder. Our mission here, to turn you into an expert engineer of the mind, ready to navigate this really challenging clinical landscape. Okay, so let's get right into it. Bipolar disorder is really all about these two poles, these two absolute extremes. On one side, you've got mania. Think of it like a rocket to the moon, an engine running so hot, so overpressurized, it's about to completely melt down. Then, on the other side, you have the polar opposite, depression. This is a deep dive into the abyss, where all the gears rust and seize up, the pipes start dripping, and the power just fails. So to get a handle on this machine, we need a good set of blueprints, right? Here's our mechanics guide for today. We'll start with the storm within, then look at the official schematics. After that, we dive into the pharmacological engine room, talk about hands-on protocols, and finally, sketch out a blueprint for recovery. Okay, let's get started. First up, the storm within. To really get this, we have to understand what it's like from the inside out. And let me be clear, this is not just a mood swing. We're talking about a state of critical malfunction.
Yeah. See, mania isn't just feeling happy or having a good day. No way. It's the engine running so hot it's threatening a total meltdown. It's a state of critical overpressurization. And the key here for diagnosis, what you have to remember, is that this abnormally and persistently elevated mood has to last for at least 1 full week. It's a major departure from the person's usual self, often so severe that hospitalization is needed just to keep them safe.
All right, now let's pull out the official schematics. We need to know exactly how we classify and diagnose these malfunctions. Understanding these blueprints is absolutely essential, not just for your exams, but for your day-to-day clinical practice. You know, managing bipolar disorder, it's a long-term project. It's not a quick fix. And it has these really distinct phases, and each one needs a totally different engineering approach. First, you've got the acute phase. This is all about crisis control, right? You're trying to stabilize a runaway engine. Then comes the continuation phase, which can last, 4 to 9 months. Here, the goal is simple: prevent a relapse. And finally, you have the maintenance phase. This can go on for years, and it's all about fine-tuning that machine for long-term, stable operation.
Okay, this is a super important distinction you have to make, especially for exams. Mania versus hypomania. What's the difference? Well, think of it like this. Hypomania is like an engine warning light flashing on your dashboard. It's a noticeable change, it lasts for at least 4 days, but it's not causing major impairment, no hospitalization. But mania? Oh, mania is a full-blown 4-alarm engine fire. It's going on for a week or more, it's causing severe impairment in their life, and it often means they have to be hospitalized.
Now for the primary blueprints, Bipolar 1 versus Bipolar 2. This is a classic exam question, so listen up. It's actually pretty simple, but you absolutely have to get it right. Bipolar 1 is all about the mania. If there has been at least one full, true manic episode in their life, that's Bipolar 1. That's it. That's the key. Bipolar 2, on the other hand, involves hypomania, at least one hypomanic episode, and at least one major depressive episode. But, and this is crucial, there has never been a full manic episode. No mania, no Bipolar 1.
And it doesn't just stop at bipolar I and II. There are other schematics to be aware of. You have cyclothymic disorder. Think of this as a more chronic, kind of lower-grade instability. It's where for at least 2 years, a person has periods of hypomanic symptoms and depressive symptoms, but they never quite meet the full criteria for an actual episode. Then you have what's called rapid cycling. This isn't a separate diagnosis, but a specifier. It's when someone has 4 or more mood episodes, mania, hypomania, depression, all within a single year. As you can imagine, that presents some really unique and difficult treatment challenges.
Okay, take a deep breath. We are now entering the heart of this machine, the pharmacological engine room. This section is absolutely critical. Mastering these tools, these medications, it's everything. This is how you effectively and safely recalibrate the mind.
So, the first and most important tools in our master toolkit are the mood stabilizers. These are your primary gyroscopic stabilizers. Their whole job is to act like these massive, heavy gyroscopes inside the machine, physically dampening those violent, chaotic swings between mania and depression. They are the absolute foundation of treatment.
All right, let's talk about the original regulator, lithium. Now, lithium is famous, or maybe infamous, for its razor-thin margin of safety. You have to burn this into your brain. The therapeutic range is 0.6 to 1.2. That's it. Anything over 1.5 and you are officially in toxic territory. You have to know the signs. Early on, it's stuff like a fine hand tremor, maybe some nausea. But as it gets worse, you'll see a coarse hand tremor, confusion, incoordination, and in severe cases, seizures, coma, and even death. And here is the #1 nursing gotcha for lithium, the thing they love to test you on: sodium. If a patient's sodium intake drops, their kidneys will hold on to lithium to compensate, and boom, toxicity. So consistent sodium and fluid intake is non-negotiable.
Okay, next up in the toolkit are the anticonvulsant stabilizers. Now these are powerful, but each one comes with a huge, high-stakes warning label. First, valproate, or Depakote. It's great for acute mania, but it can be toxic to the liver and pancreas, so you have to be monitoring liver function and amylase. Then there's carbamazepine, or Tegretol. This one can cause granulocytosis and aplastic anemia. Basically, it can shut down your bone marrow, so you're watching the CBC like a hawk. And then lamotrigine, or Lamictal. This one has the warning you can never forget: Stevens-Johnson syndrome, or SJS. It can start as a simple rash, but it can turn into a life-threatening emergency where the patient's skin literally starts to peel off. The only way to prevent this is to titrate the dose up very slowly, and to teach your patient that any rash, needs to be reported immediately.
Let's talk about the engine coolants, the atypical antipsychotics. These are fantastic for managing that overpressurized state of acute mania, especially if there's any psychosis involved. But they come with a big, long-term trade-off: a high risk of metabolic syndrome. We're talking significant weight gain, messed up cholesterol, and altered glucose that can lead to diabetes. So you're constantly monitoring weight, BMI, glucose, the whole 9 yards. And then there's clozapine. This one is in a class of its own. It's a last resort for treatment-resistant illness because it works when nothing else does, but it carries a deadly risk of agranulocytosis. That's why patients on it require strict, weekly white blood cell monitoring at first. It's a high-risk, high-reward kind of tool.
Okay, people, this is it. This is your master blueprint. I want you to pause here, take a screenshot, burn this into your memory. This single slide has the most critical, most testable information we've covered. Let's run through it one more time. Lithium, toxicity above 1.5, watch that sodium and fluid intake. Valproate, think liver and pancreas, so monitor LFTs. Lamotrigine, think rash. Any rash could be Stevens-Johnson syndrome. Carbamazepine, think blood, CBC, risk of agranulocytosis. The other atypicals, think metabolic syndrome, weight, glucose, lipids. And clozapine, agranulocytosis again, but so serious it needs its own strict WBC monitoring protocol. Got it? Good. So, now that we have a solid grip on our pharmacological toolkit, we can shift our focus to the hands-on work. This is all about engineering patient stability, the nursing interventions that create a safe, therapeutic environment where the system can actually begin to recalibrate. When you're faced with acute mania, you're dealing with a system in total overload. You need to initiate the emergency overpressure protocol. Step 1, decrease stimulation. Get them to a quiet room. Dim the lights. Step 2, provide portable nutrition. They are burning through calories but won't sit down to eat. Think high-calorie finger foods and drinks they can take on the go. Step 3, set firm, consistent limits. They need structure. Use short, simple, direct statements, no negotiation. And Step 4, redirect energy. That incredible physical energy has to go somewhere. Guide it into safe, non-competitive activities like just walking.
Your communication in these moments, it's a precision tool. You have to calibrate it perfectly. Their thoughts are racing a million miles an hour, so you need to be the opposite. You have to be calm, but firm. Use short, concise sentences. Stay neutral. Do not get sucked into power struggles or arguments because you will lose and just make it worse. Be consistent. Every single person on the team has to have the same approach. This is how you de-escalate, how you maintain that therapeutic connection without throwing more fuel on the manic fire.
And remember, the environment itself, what we call the therapeutic milieu, is literally a part of the treatment. It's not just optional. A safe, structured, low-stimulation environment is a core component. Think about it. Your job as the engineer isn't just to fix the machine, it's to make sure the entire workshop is calibrated for safety and stability. That's how healing can even begin. All right, let's head into our final section and see how all of this comes together. We're moving from crisis management to creating a blueprint for recovery, for turning that chaotic, shuddering machine into one that's calibrated and runs smoothly.
And here it is. This is the complete system on one page. This is your final blueprint. You can literally see the lines connecting the malfunction, mania, depression, psychosis, to the right tool for the job, whether it's the lithium gyroscope or the olanzapine coolant pump. And notice how all those critical dangers, all those flashing warning signs are right there next to the tools that carry them. It's about connecting the problem to the solution and never, ever forgetting the risks involved.
So, we'll end with this question. You are the engineer, you have the blueprints, you have the master toolkit. When your patient's world is a raging, out-of-control storm, how are you going to use this knowledge? How will you become that calm, steady hand that helps restore the balance? Because mastering this stuff isn't just about passing a test. It's about accepting the profound responsibility of being that skilled, compassionate engineer for a mind in crisis.